The Nurse Theorists, Portraits of Excellence. In this edition, we feature Dorothy Johnson.
Well, I'd been collecting shells for a long time. My brother gave me some shells that he'd gotten in his shrimp nets off the Yucatan Peninsula, and they were so beautiful. I couldn't believe how beautiful they were. In fact, it was that led me to learn to snorkel, because you can't really see them from the top of the water. You don't know that they're there, and a lot of people swim over shells all the time and never see them. They're well camouflaged sometimes, but sometimes they're not. And they were just so incredibly beautiful, their form, their shape, and there were so many of them. I couldn't believe how many different shells there were. So little by little, we got more and more involved in them as we gathered more books to learn about shells more, to identify the shells we had, and got interested in the anatomy and physiology of the creatures in the shell. As a matter of fact, I use shells trying to help students recognize that you have to know the terminology in order to be able to observe anything about a shell. To describe its shape or its color or anything else, you have to know what the terminology is. And I was trying to help them see at that point that you perceive only what you've got in your head to see. And it was interesting as an experiment with classes. We'd done most of our shelling in the Pacific. We thought we ought to give the Caribbean and this coast a try. So we saw this property and decided if we were going to settle on an island, that maybe Key Largo was the best place to settle. Close enough to Miami for health facilities, and close enough for other kinds of activities. So that's why we chose Key Largo. Well, I was born in Savannah, Georgia in 1919. I was the last of 7 children. My father was the superintendent of a shrimp and oyster canning factory in Savannah. They had their own boats and brought in the shrimp, and they had their own oyster beds that they collected from. My mother was a very active woman and interested in a lot of things. She was an avid reader, and she introduced all of us to reading very early. A typical night at home after the news was everybody settled down with a book. My brothers were mostly older, and my sister was considerably older than I was. So though it was a large family, it didn't seem so, because they were never at home at the same time. In fact, my sister was married when I was 1 year old, so you see what a spread we covered. I not only grew up there, I went through the first 2 years of college in Savannah, Armstrong Junior College. And when I graduated from there, it was getting toward the end of the Depression, but financially things still weren't very good. And I couldn't figure out how I was going further at that moment. I took a year off and went to Miami as a governess for 2 little girls on Miami Beach, and that was a fun year. It did stimulate my interest in children, and I think that accounts for the fact that I chose the field of pediatric nursing as my clinical interest. At that time, Vanderbilt was one of the very few schools in the country that offered a baccalaureate program in nursing. That attracted me because I obviously wanted to go further in college, and that was ideal for my purposes. I had a year in public health nursing, and then I had an experience of 4 or 5 years, I can't remember exactly how long, teaching at Vanderbilt. And I returned to Vanderbilt for a year after I got my master's degree, and then I went to UCLA.
Well, I met Dottie when she came into the Vanderbilt School of Nursing. You can depend upon Dottie as a human being and as a friend, and almost any way you can imagine. When I left Vanderbilt and came to UCLA to start the School of Nursing, I could think of no one that I'd rather have to be a faculty member than Dottie, and I was able to lure her from Vanderbilt. And she did a tremendous job for us there, helping to back up the kinds of things that I was trying to do. She talks about evolving science of nursing, and by her very scholarly performance, she stimulates students and faculty.
Well, I met Dottie when I was first employed at UCLA School of Nursing. Dottie is the image of a nurse scholar. There is no one like her as far as I'm concerned. I want to say that read everything she's written, because it doesn't get outdated. It's current, it's contemporary, even 30 years ago. It's certainly shown me the importance of developing a knowledge base for nursing practice.
In 1955, I was eligible for sabbatical, and so I chose to go to India under our program of aid to underdeveloped countries through the State Department. And I went to a little community in India called Vellore. It was a missionary school established by an American woman whose name was Dr. Ida Scudder. She thought there ought to be somewhere in India a medical college that would accept women, and she branched very quickly from just medicine to nursing and eventually to other health professions. I was attempting there to establish a baccalaureate program, or pediatric portion of the baccalaureate program. I had lots of interesting experiences in India with students and with patients. When I was there, Nehru, who was then Prime Minister, came to town to speak, and he came to Vellore. I saw Mrs. Indira Gandhi at the same time. She came with Nehru, and while I had a marvelous opportunity to talk to both of those people, one that I would never have thought I would have, it was an interesting experience, too, to see the reaction of the people to Nehru. He was almost worshipped by the Indian people. I've never heard 300,000 people absolutely silent before, but I did when he spoke. I went back to UCLA. Very shortly, I moved entirely to teaching in the graduate program at UCLA, and we did a lot of interesting things in that program. A number of my brothers had already died when I found out I had coronary heart disease. And I must say that changed my value system considerably. I have often been queried about why I never published a paper that's been widely circulated, the first real presentation of the behavioral system model. And it's because I changed my value system. I'm quite honest about it. Nursing wasn't my whole life anymore. And so it took me a few years to get over both the surgery and that experience, to realize I was really mortal. And that did have an impact on my career.
In an interview at Christine's restaurant at the Key Largo Sheraton, Ms. Johnson discussed her behavioral systems model with Dr. Jacqueline Fawcett.
Dorothy, I want to tell you how pleased I am that you agreed to this interview. It is an honor and a privilege that you agreed to meet with us.
Thank you so much for coming. It's really my pleasure.
Dorothy, you have written that the behavioral system model evolved from your concern about the development of nursing as a science and as a profession. Would you tell us more about that concern?
Well, it really started, I suppose, when I was a student, because we were imbued with the idea that nursing was a profession and that as such it had an original responsibility to patients, and that in order to fulfill our responsibility, we needed a body of substantive knowledge. And I became increasingly concerned when I started to teach and realized that out of all the knowledge we have available, I didn't know what we should include in nursing except what had been done before me. And so I started looking for a rational basis both for presenting knowledge and for building on that knowledge.
Who or what influenced you as you developed the behavioral system model?
Well, you know, that took place over a great many years, long before I began to speak or write about it. It actually started when I started teaching, and I happened to receive from a book publisher at that time in the mid-40s a facsimile of Florence Nightingale's little book, Notes on Nursing. I brought it along with me. It's well worn, as you can see. At any rate, I thought that's the place I really ought to start. What did she have to say? And she titled her book, subtitled her book, Notes on Nursing, What It Is and What It Is Not. And so I thought, well, you know, this is really the place to begin. And she led me to believe that the nursing's primary concern was the relationship between the person and his environment. I went through a lot of stages trying to think that through, what particular aspect of the person or the environment. And it was over a period of, I'd say, at least 15 years before I got to the conception of man as a behavioral system, and went through many stages, using it in teaching all the time for the organization of coursework and for the selection of content. So that's Florence, I'd say, was the first. Perhaps before Florence, in a sense, was Lou Hassenplug, who convinced me nursing is a profession. And then as I continued with these ideas, many people contributed in one way or another. Students contributed, faculty contributed, colleagues across the country contributed. At one point at UCLA, we undertook a project to delineate knowledge to be included in master's programs under the auspices of the Western Interstate Commission on Higher Education. And that whole faculty group throughout all of those schools in the West participated in trying to develop content. So a lot of people have had influence here, not the least of which that small group of faculty at UCLA who worked so hard to build a curriculum based on this model.
The behavioral system model has been particularly helpful and useful in the development of nursing curriculum. But what has been the influence of the model on nursing practice?
Well, the students are taught the model in order to use it for practice. And if the effect on patient care is what I think it ought to be and should result from the use of the model, clearly it has many implications for practice. It has been used by many people in practice. In fact, the whole Neuropsychiatric Institute at UCLA uses this model for practice.
How has your work influenced nursing research?
Well, I know that there have been quite a number of doctoral theses built on the model, and that some research has gone on after the doctoral degree was received.
Do you think that the behavioral system model can be used to structure the delivery of nursing services in the sense of the administrator using the model?
Administrators have used the model to set up standards for nursing care, for evaluation of nurses in giving care and that kind of thing. I think it has great potential in that area. I don't think it's been fully utilized to that extent yet.
I thought you'd be interested to know that the model is being used or has been used at the Naval Hospital in Philadelphia. One of my students in the master's course that I teach at the University of Pennsylvania on conceptual models decided to use the model and went to her head nurse and got permission to do it. And it was being used by everyone on the unit, the nurses' aides, and even the psychiatrist was using it. all of the charting was done in the context of the behavioral system model, and it was working absolutely wonderfully well.
That's great.
That leads me to another question. You have written that nursing, and I will quote here, is a service that is complementary to that of medicine and other health professions, but which makes its own distinctive contribution to the health and well-being of people. Would you identify then the distinctive contributions or viewpoints of various health professions? How, for example, does nursing differ from medicine?
Well, it's been clear for many years that medicine uses as its conceptual model the man as a biologic system. I think the conception of nursing, of the nurse on man as a behavioral system is very complementary to that. I think the social worker's conceptual model might well be man as a social system. They do tend to complement each other, and it takes all of them together to make a whole man.
Dorothy, would you tell us more precisely what you mean by the person as a behavioral system?
It is, as you know, a conceptual model, and it's only a concept. It's a way, a perspective, a way of looking at a person and dealing with some limited aspect of that person, both in practice and in research. As I constantly told students, it's not a concrete thing, and it doesn't make the person mechanistic for you to view him in this way. It's simply a way of handling, in a theoretical sense, how and what limits the nursing role.
But more precisely, what do you mean by behavior and the behavioral system?
Oh, I see. Well, it's built upon the notion that all the repetitive and patterned ways of behaving that we can see in the human being are the output of his behavioral system. And that output can be described, it can be explained, it can be predicted, and someday we'll know more about all of those things. But it is already, we have enough knowledge to do much of this kind of thing.
How does the model lead to nursing actions in situations such as giving medications? For example, when my students say, how would the behavioral system model be used to give medication for someone in pain, I ask them to describe what they mean by pain. And invariably, they come up with a discussion of pain as a physiological event. My response then is that from that perspective, the behavioral system model would not lead you to the nursing intervention of giving the pain medication. So what would you do? How would you help that student perhaps to see pain differently, or to accept that perhaps from your perspective giving pain medications is not in keeping with nursing?
I think if the student sees that as a physiological event, she doesn't really understand the nature of pain. That's one answer that one would give. Obviously, pain is a manifestation that stems from a number of sources, not simple physical sources. I would also, however, at the same time point out to her that just because pain doesn't fit readily into the behavioral system model doesn't mean that she fails to deal with that situation. She's dealing with a behavioral system that is in pain, responding to a noxious stimulus, if you will, but she's also dealing with pain in a biological system, and she's got to combine actions directed by both of those models in order to serve the patient adequately.
You have written that the 7 subsystems of the behavioral system model are sufficient for now, if not for always. You've also indicated that you don't see a particular need for the restorative subsystem that has been used in some interpretations of your work. I wonder if you could comment on that.
Well, the faculty used that one, I think largely as a matter of expediency, because they didn't know where to put some things like sleep and rest and diversion. and it seemed to them they needed to include that in the curriculum. So that's how that subsystem got initiated, shall I say. I can't justify it as being derived from a motivational structure. So I can't include it in any logical way in my thinking.
Where would you put sleep then?
I suppose if sleep is important to consider, one would use it under a biologic system, not under the behavioral system.
I kind of think about sleep, for example, as part of the achievement subsystem.
That's an interesting notion. I hadn't thought of it that way.
Or maybe even the aggressive protective subsystem.
That sometimes is the case. I would agree with you on that score. Achievement I hadn't thought about at all. That's an interesting notion to follow up.
That leads me to ask you, how do you help people to think from the perspective of the behavioral system model, rather than thinking from some other perspective and trying to put all of those things into the behavioral system model?
It's not easy. I have to constantly, or did have to constantly remind students, this is a useful tool, an analytic tool, and you've got to keep it firmly in your mind if it's going to result in anything that's cohesive and unified in what you do for patients. It should lead you to actions which you can tell when you've used it effectively because of the outcomes in patient care. And you should know by the use of the model fully when you've done everything you should do as a nurse. And you know where to stop and where to start as you begin to assess patients. But it is a new way of thinking for most students in nursing these days. And it takes a long time, I think, to train oneself to use it adequately.
It seems that it eventually becomes a habit. In fact, Brancadello has written about the use of a model eventually becoming a habitual way of thinking.
That's a very good
nursing.
way to put it.
You now live here in Florida and have not written recently about the behavioral system model, although I was delighted to see your editorial recently in Dimensions of Critical Care Nursing. What is happening now with the further development of the behavioral system model? Who is working with it?
I don't really know. I'm not actively working on the model myself. I don't have the resources. I've given my all, as far as I'm concerned, to that model. And if others who have seen promise in the model develop it further, I'll give them all the support and encouragement I can. And there's reason to believe, I think, that there are some people out there working on it.
I do understand that Bonnie Holliday has been presenting some of her work, which is an interpretation of your model.
Yes, I think it is. I might mention here, and Bonnie knows this is how I feel about it, that I don't agree with the use of the ingestive system and the eliminative systems, subsystems, as being the input and output systems, because I think that disrupts the whole nature of the behavioral system that I've presented. I think they did that for many reasons. But in my view, that was the faculty, again's idea of how to treat it. And, you know, they have a right, it's in the public domain, to do anything they wish with those ideas. But my disagreement with it is that all of the subsystems have input, just as most of the biological subsystems, and probably all of them, have input and output, and it does not come through a single system. So with that one disagreement with Bonnie and others who've written about the model, I think Bonnie certainly is doing a great job in forwarding the idea of the model and using it actively in practice and research. And I'm sure there are others as well.
The fact that Bonnie's work is presented clearly as an interpretation of the model is very important, I think. I've always been concerned that people present the model either in its pure form or, if it's modified, indicate that it's a modification.
I agree.
What are you doing now, Dorothy?
I'm having a great deal of fun living, enjoying life, collecting shells, traveling as much as I can. And I also do have a good deal of discussion by telephone, sometimes conference telephone calls, by correspondence with many people across the country and in other countries about the model, and I help all I can to either clarify something or to go further, and that I'll continue to do, of course. I hope there'll be many more years of that.
It's wonderful that you're willing to participate at that level and talk to students and faculty and clinicians who are using the model. I'm sure it's extremely helpful to them.
I enjoy it, needless to say.
Do you miss being actively involved in teaching and in further development of the behavioral system model?
A part of me misses that very much. I'm always delighted when I go back to California or see students here who come to visit me, and brings back some of the stimulation and and we get into serious discussions sometimes about what's going on, and that's fun. But I've, in a sense, given it up in a very real way by choosing a different lifestyle.
I'm so pleased that you were willing to do this interview, to take time from your wonderful life here in Florida and elsewhere to talk to us about your work and your life and your thoughts about the behavioral system model. I've certainly appreciated it, and I'm sure our audience will also.
Thank you so much for coming. It's really my pleasure.
But it was probably after I had graduated and was working as a clinical specialist that I began to know her as a person, her interest in your career, and she was so interested in her students. She's still out exploring. Again, I think any good scholar explores not only their theoretical material, but they explore life. And her interest in shelling has taken her around the world, and she's a risk taker.
That Dottie was 20 years before her time. What she wrote about in the 60s, in the early 60s and mid-60s, are some things that are being written about now. They are better heard now because the climate is ready for it, to hear it. But perhaps when it was written there, it was so esoteric and so unusual that people didn't grasp it and didn't understand it. We are just beginning to understand what Dottie was talking about, nursing as a science, nursing as a discipline, and that we really cannot provide clients, patients, society with appropriate nursing care unless we are able to identify it, articulate it for ourselves, and therefore articulate it for the public.